At the outset, my sincere thanks to Banshi, Dr. Rutul, and the entire team for making me part of this DiaObecon. So my talk is on steroid-induced hyperglycemia. So this is the timeline, how the key historical developments with respect to the steroid-induced diabetes, so which was the thing after cortisone was introduced in 1930, then 1950, still the case reports has been detected with respect to the steroid-induced hyperglycemia, and 1970s formal investigations has been done, and way back in 2000 the mechanistic understanding was developed. So let me start with this growing clinical challenge of steroid-induced hyperglycemia. So it represents one of the most important challenging complications with respect to diabetes, and it has a high prevalence. Nearly 64 to 71% of patients receiving steroid, they approximately have the chance of getting worsen of diabetes. Secondly, it's a complex management, and thirdly, it is under-recognized. So let me start with this clinical case of 62-year-old man with a 12-year history of diabetes, well controlled on OADs. His baseline HbA1c was 7.5, and he was treated for some arthritis and was given oral prednisolone 40 milligram daily. So this was the thing, and after that, the dramatic glycemic deterioration. So within 48 hours of the prednisolone initiation, the patient had a dramatic increase in the baseline investigations and the postprandial. So from fasting 140, it went to 240, and postprandial from 240, it came up to 420. So this postprandial elevation, so it represents a particularly worsening development indicating severe insulin resistance and impaired glucose disposal. So these are the things where it places the patient at immediate risk for acute complications, which you know, and delayed wound healing. So this rapid onset underscores the importance of anticipatory diabetes management when you start a steroid. So what are the metabolic disruption with response to steroid-induced hyperglycemia? So first is the blood glucose 4, where it causes the elevated glucose. Secondly, it has an impact on the hepatic glucose output. Thirdly, it reduces the peripheral glucose utilization, and lastly, impaired beta cell response. So these are the things. So what happens in a steroid-induced hyperglycemia? So these are the patterns of hyperglycemia with respect to the steroid-induced hyperglycemia. First, the morning fasting levels. So the fasting glucose levels, they remain near the baseline values. So this occurs because the steroid effects have diminished overnight, and hepatic glucose production returns back to the normal levels. Secondly, the most important thing is the midday elevation. So the steroid levels peak following the morning dosing, and the glucose levels begin to rise significantly. So this coincides with the increased insulin resistance and enhanced hepatic glucose production. And thirdly, the most important thing, the afternoon and the evening peaks. So these occur during the afternoon and evening, corresponding to the peak steroid activity, and the postprandial glucose excursions are particularly pronounced during this particular phase. And lastly, once again, the sugar comes back to normal at the night time. So this occurs as the steroid effects wane. So the main thing is the afternoon and the evening glucose spikes. They represent the most important critical period during the steroid therapy. So what is the clinical impact on the steroid induced? First, compromised infection control. Secondly, delayed wound healing. Last, extended hospital stay and increased complication risk. So these are the three important aspects how a steroid induced hyperglycemia have. So what are the risk factors? So high HbA1c, beta cell advanced type 2 diabetes, who are getting high steroid dose, prolonged duration, and multiple comorbidities. So what are the monitoring strategies? So we need to have certain protocols. So first thing is 4-point SMG or a CGMS or hospital monitoring. So nocturnal surveillance, continuous glucose monitoring, as I told before. So always these things, pre-meal glucose levels and 2-hour postprandial are the most important things which you need to take into control with respect to SAG. So what about the management principles with respect to steroid-induced hyperglycemia? First, the OADs. So metformin should be continued unless it is contraindicated, and as it helps to reduce the hepatic glucose neogenesis, and where with respect to sulfonylureas, they are for acute steroid effects but may be added cautiously. With respect to DP4 and SGLT2, they provide some benefit. The main thing is the insulin therapy. So NPH insulin represents the ideal choice for steroid-induced hyperglycemia. So its intermediate acting profile, they perfectly matches with the afternoon and evening hyperglycemic pattern. So lastly, the steroid tapering conditions you should to take into consideration. So coming back to my case, so this male patient was successfully managed with NPH 12 units and concurrent with his prednisolone dose, and the timing strategy effectively covered the afternoon and evening. So regular SMG monitoring was done and he had an improved glycemic control. So always predict and prepare. So anticipate the steroid-induced hyperglycemia in all diabetes patients. So afternoon and evening spikes with morning normalization, they are the most important with respect to the clinical patterns with respect to steroid-induced hyperglycemia. And insulin, NPH insulin will be an ideal choice which gives an optimal coverage for the steroid-induced hyperglycemia, and prompt recognition and insulin initiation prevent the serious complications and improve outcomes. And lastly, gradually reduce the insulin as the steroids are tapered, so to prevent hypoglycemia with respect to all patients. So thank you all for your patient hearing.